My name is Dr. Joseph Hsu. I'm a corneal specialist and a general ophthalmologist practicing in the Los Angeles area. I'm double fellowship trained from Downey, USC, and from the Wilmer Eye Institute. I've been in solo practice now for 12 years and started performing canaloplasty only 1 year ago. During this period, I have performed over 110 cases, currently perform 10 to 12 cases per month, and have performed up to 6 cases in 1 day. Now, some of you may have done some cases, but are still trying to get over the learning curve. Some of you may have done more, but want to ramp up your volume. I wasn't much different than you were a year ago. Nevertheless, I was able to adopt canaloplasty quickly, get over the learning curve, and ramp up my volume in a very short period of time. So I'd like to share with you my experience in how I adopted canaloplasty and my patient selection. 2 years ago, Adam Bernstein, my local eye science rep, came to my office and introduced me to canaloplasty. At that time, I really didn't know much about canaloplasty, didn't see any long-term data, and dismissed it. A year later, he came back with exciting news of newly published data showing how safe and effective canaloplasty was. 3-year data shows that with canaloplasty alone, the intraocular pressure dropped by 34% and in medication by 53%. When combined with cataract surgery, the pressure dropped by 42% and medication by 80%. It also showed a better safety profile than trabeculectomy. I was intrigued by what I read and agreed to take the didactic course and wet lab at ASCRS last year. There I listened to Dr. Robert Sinsky talk about his own personal experience as a patient, and to Dr. Ralph Chu talk about himself getting into canaloplasty. Now, I've known and respected Dr. Chu for many years and thought that if he, as a corneal specialist, was getting into canaloplasty, then it probably was a procedure worthwhile getting into. At the wet lab, I was surprised how readily I was able to dissect down fine Schlimm's canal, cannulate it, and stent it. I felt with this experience, with practice, I could do the procedure well. So I contacted my local eye science clinical specialist, who set up additional wet labs for me to practice on cadaver eyes. She also came by and trained the OR staff. I then proceeded to schedule 14 patients in the first 7 weeks and felt that by doing this number of cases, it helped me become more proficient in doing the procedure and not having to relearn steps. My early cases included patients with advanced glaucoma in line for a trab, patients with uncontrolled glaucoma on 2 or more medications, and cataract patients with glaucoma. My first few cases took me 1.5 hours to 2 hours to perform. Later cases took me an hour. And now that the OR staff and I are faster, it usually takes me around 30 to 45 minutes to do a case. So don't get frustrated over your first few cases. During these early cases, I was able to cut down to decimates on all cases, cannulated all but one, and stented the majority. I did perforate decimates on a few cases. Postoperatively, all patients had transient blurred vision, and the majority had hyphema. Now, despite not being able to stent all cases and perforating decimates in a few, it was gratifying to see that everyone had lower eye pressure, and only one had a pressure spike that required additional medication. Vision was recovered in all on an average of 1 to 2 weeks. In all the cases I performed, I've not had to convert to a trabeculectomy. Now, having done this, many cases allow me to gain confidence and broaden my patient selection. In thinking about patient selection, we should understand the indications. Canaloplasty is approved for open-angle glaucoma. It can be used as a first-line treatment before or after laser surgery for patients who are non-compliant or intolerant to medications, in exfoliative or pigmentary glaucoma, and after fill laser or trabecularly on the fellow eye. Contraindications include neovascular glaucoma and angle closure glaucoma, angle recession, and patients with peripheral anterior synechia. Caution should be taken on patients with narrow angle glaucoma. I like to divide prospective patients into mild or moderate glaucoma, advanced glaucoma, and cataract patients with glaucoma. It is important here to understand that canaloplasty, unlike previous glaucoma surgery, is not just for advanced glaucoma. It is well suited for mild to moderate glaucoma. In fact, the majority of the cases that I perform are from patients with mild to moderate glaucoma. We all have patients who have mild to moderate glaucoma who are non-compliant because they are forgetful, they find medications too costly, or putting eye drops doesn't fit with their lifestyle. There are sick and elderly patients who lack help for their eye care or don't have transportation to get medications. There are also patients who are unable to comply because of mental deficiencies such as Alzheimer's, dementia, or psychiatric disorders. Physical disorders such as arthritis or poor vision, and patients who are intolerant to medication because of irritation and redness. Canaloplasty can be used for advanced glaucoma in lieu of trabeculectomy or shunt surgery. It is less invasive, has a better safety profile, less chance of creating a bleb, therefore less post-op irritation. Vision recovers quicker, has a lot less rocky post-op period, and does not obviate future glaucoma surgery. Here, 3-year data shows that canaloplasty has a lower complication rate in terms of hypotony, cortical detachment, and endophthalmitis compared to trabeculectomy. Cataract patients is another good source. Many have glaucoma. You treat 2 diseases with 1 surgery, although you may want to stage the surgeries to get better post-op uncorrected visual acuity, especially if you're doing premium IOLs. It's a win-win situation for both you and the patient. Now, in order to ramp up your volume, it is important to be confident and believe in the surgery. Train your staff, let them see the results. iScience provide excellent educational pamphlets and posters. I have posters throughout my clinic, in the waiting area, and in examination rooms. Patients frequently see the posters and ask me about this new treatment for glaucoma. iScience also provides booklets to help you explain the procedure to your patients. So, in summary, canaloplasty is less likely to be associated with a bleb. It has less complications than a trabeculectomy. It is restorative, not disruptive. Vision recovers quicker. It allows you to intervene at an earlier disease process and get the patients off medications. I do recommend doing a lot of cases early to get over that learning curve. And in time, patient will be selecting you and help expand your scope of practice. Remember, canaloplasty is the only glaucoma treatment that addresses the broad spectrum of mild to moderate glaucoma through advanced glaucoma. Thank you.